Good morning. I'm Ana Sofia Ore. I'm one of the surgical residents at Beth Israel Deaconess Medical Center in Boston. Thank you for allowing us to present our work today. I will be presenting our evaluation of a sutureless anastomosis using the self-forming magnetic anastomosis system in a porcine model. These are our disclosures. So this was an investigator-initiated study, initiated by the surgeons performing this preclinical study in collaboration, as you can see, between multiple institutions, GI Windows Finance, to evaluate the safety and outcomes in this porcine model with the end goal of transitioning to a clinical trial in humans. As a bit of a background, standard of care for small bowel anastomosis for ileostomy reversals can be in two approaches. One of those are the hands-on anastomosis, and another one is a stapled anastomosis, both with comparable outcomes. One of the benefits of a hands-on anastomosis is that it's a true end-to-end anastomosis. Another benefit of a stapled anastomosis is that you're able to create a uniform anastomosis in a decreased time. Something to keep in mind is that both approaches use foreign materials, which has been found to cause a local inflammatory response. It causes tissue injury, scarring, and studies have found bacterial overgrowth and bowel distortion. All this can potentially lead to postoperative complications, such as ileus, small bowel obstructions, and anastomotic leaks. So the self-forming magnets. The self-forming magnets we use are octagonal-shaped magnets with 25mm diameter that have rounded edges to promote both healing and safe migration. Our hypothesis was that the use of these magnets could safely create an end-to-end small bowel anastomosis, with both decreased inflammatory and fibrotic response when compared to standard of care approaches, with no permanent foreign body left behind. In order to perform this, we performed a good laboratory practice porcine study in 14 subjects. All of them underwent extracorporeal small bowel anastomosis. The survival period was 6 weeks, and we divided them in 3 groups. 6 underwent anastomosis using the self-forming magnets, 4 underwent a hands-on approach, and 4 underwent a stapled anastomosis. Our primary endpoint was both safety and efficacy of performing the anastomosis, and we also were able to measure anastomosis creation time, lumen diameter, burst pressure, and then a histology evaluation. As we can see here, the magnets are being delivered into the lumen of the small bowel. With previously placed purse string sutures, we are able to manipulate both segments of the bowel, and we're able to determine the adequate position for magnet pairing. Once it's in the right position, the purse string sutures are removed. Here you can see the final product of what the anastomosis looks like. Like I mentioned before, there are 25mm diameter magnets, and they allow for a seamless passage of a 12mm endoscope. This is the intraluminal view of what the magnet anastomosis looks like. The magnets are expelled through the fecal stream. In our study, we found that all magnets were expelled between day 10 and 17. This is an endoscopic view at day 12, where we can see a healed anastomosis. There's no inflammation, there's no adhesion, and there's no scarring. On our study, that we were able to safely perform 6 anastomoses on our porcine model. Looking at other results, we can see in procedure time, the magnet group had a mean time of 17 minutes, compared to a mean of 10 minutes for the staple group and a mean of 28 minutes for the hands-on anastomosis group. Something to note for the magnet group is that our learning curve improved significantly, and we were able to decrease to 11 minutes by case 5 and 6, having comparable outcomes to the staple group. We were also able to measure anastomosis tissue thickness, and we were able to determine that the magnet group had a slight increase in tissue thickness at the level of the anastomosis from a baseline of 2 to 2.9, compared to an increase in thickness for the staple and suture group from 1.9 to 5.9. There was no reduction in lumen diameter for the magnet group, and there was a slight reduction of lumen diameter for both the staple and suture group of 0.2 millimeters. When evaluating adhesion scores for all 3 groups, the magnets had the lowest adhesion score. And you can see here in this macroscopic view that it's very hard to determine where the anastomotic line is. There's no bowel distortion and there's no scarring. All of the groups underwent also leak tests. And as we can see on the right, there is the magnet group achieved higher burst pressure levels compared to the staple group, and in some cases very similar to the hands-on anastomosis group. In this histological view, macroscopically, we can see that for the magnet group, it's very hard to differentiate where the anastomosis was formed. There was less of a 1 millimeter line seen macroscopically. Additionally, when we were able to review the slides, no granulomas or macrophages were found on the magnet group. And then compared to the staplers, we can see macroscopically there's bowel distortion, and we can clearly see where the anastomotic line is for the stapler group. On slides, we were able to evaluate, and there was both presence of granulomas and macrophages, indicating active inflammation in the staple group. So to conclude, we were able to safely perform a small bowel end-to-end anastomosis using the self-forming magnet device in a porcine model with no devices retained. Time to anastomosis was faster than hands-on approach and achieved an optimal learning curve, achieving comparable times compared to a stapled approach. Safety was confirmed with burst tests for all 3 groups, and there is histological confirmation of less scarring, no active inflammation, and less intestinal distortion. We were also able to find that the distal diameter of the anastomosis was bigger compared to other approaches. Trials in humans are needed in order to confirm safety and efficacy in small bowel anastomosis. We are actively recruiting sites for our clinical trial. Thank you, and I'm happy to answer any questions.